So, how does the age of the patient impact your approach to treatment?
We're always more cautious and thinking much more about safety in younger children, but even in adolescents. With pediatric care, it's all about what is safe. And we'll sometimes give a little bit on efficacy to make sure we're dealing with something safe. Now, nowadays, we've got great treatments, a growing number of topical treatments, and that's important because the vast majority, probably about 80%, maybe even more of the psoriasis that actually occurs during childhood is mild, not moderate to severe. But we've also got a broadening range of biologics, well beyond the methotrexate psoriasis that we used to use. And now we have apremilast approved for children, so that's an oral beyond methotrexate, and a new IL-23, the inhibitor that's oral, not a biologic, is really looking good in trials.
So, what is your approach to treatment as far as topicals and biologics go? When do you decide which route to use? And do you ever use combination therapies? Is that common?
Obviously, going to a systemic medication depends on the severity of the patient. We don't have clear criteria in pediatrics. We can think about that 10% body surface area, but we also need to think about the impact on the individual, the response to the topical steroids, and where they have the disease. Because you can have just disease on some of your nails, but it's recalcitrant and it's embarrassing. And then we may have to think about a systemic agent. Now, the one that I choose, to be perfectly honest, may depend as much on access as it does on my clinical decision making because our patients may have an insurance that does not allow them to easily get the medication that I may want them to have. And that certainly is often true of a biologic. It's not first line in many of our patients based on their insurance.
Interesting. Let's talk a little bit about comorbidities. What are the common comorbidities that you typically see, and how do they impact psoriasis?
So there are many comorbidities that have been associated with psoriasis in the pediatric population. By far, the most common one is obesity or overweight as well. And we and others have suggested that there's a strong link with obesity, softer link with some of the other metabolic issues that may occur. In a study that we did many years ago with a relatively small number of children, but such overwhelming results, we showed that 92 to 93% of those children who were obese or overweight at least 2 years after had obesity and overweight at the time of the onset of the psoriasis, had that for at least 2 years before the onset of the psoriasis, and then continued for at least 2 years afterwards to have that same profile of high percentile of body mass index. And that suggests that when we see psoriasis with obesity in children, it's not because the psoriasis occurs and then because of the fact that they may not have the same lifestyle or may not be feeling as good about themselves, may have some depression, that they gain weight. Rather, it's a comorbidity of obesity. Now, we actually do see psoriatic arthritis. It's called juvenile idiopathic arthritis in children, and it's a small subset of that group. But it is something that occurs infrequently. So overall, only a little less than 1% of all the children that we see with psoriasis. But we need to be on the lookout for it. And the other major one is inflammatory bowel disease, Crohn's in particular, but also in some studies, ulcerative colitis. And then, of course, the comorbidity of mental health issues. And again, I don't know if that's primary, secondary, but both anxiety and depression have been linked, not only in the children, but in the caregiver as well.
Understandable.